biggest problem with most EMRs is what we call disaggregation of information. You have information stored in multiple different parts of the chart. And so you have this hunt and peck model where if you are trying to access the patient's lab results, you need to click over here. And if you want her recent set of vital signs, you click here. But if you want to look at the 12-hour trend, it's in a different part entirely.
Yeah.
And, and when you are doing that sort of hunting and pecking, the information inevitably can get missed.
Welcome, everybody, to Reimagining Healthcare, a new dialogue with risk and patient safety leaders presented by MedPlace. We're excited to bring you conversations with top risk and patient safety thought leaders from organizations across the country. Please subscribe to get the latest news and content. And if you found this episode valuable, please share it with your colleagues to create some meaningful dialogues in your own communities. If you're interested in participating as a guest, please feel free to email us at speakers@medplace.com. And also check out our related content like articles, videos, and more on blog.medplace.com/resources. My name is Jared Bailey. I'm the CEO and founder of MedPlace. I'm going to play host today. And today I'm joined by Dr. Stephen Porter, CEO of riskLD, a healthcare or health tech startup, much like us, with a focus on OB/GYN risk. Welcome, Steve. How are you?
Very well. Thank you for having me, Jared.
So I got to know you at a conference that we were at relatively recently, and I love learning about tech startups that are in the space that are solving problems around risk and patient safety. It's obviously where we're embedded as well. And I was really impacted by what you had to share. You guys have some pretty impressive metrics, and you've built a tool, I think, to help support what you're doing, and kind of interested in unpacking some of that today.
Absolutely. We're delighted to be sharing our story with you.
Great. Well, all right. So what is riskLD?
Sure. So riskLD is a patient safety solution. It is a software platform that fully integrates with the inpatient electronic medical record, and it provides a combination of early warning and clinical decision support at the point of care on labor and delivery and postpartum. So the
Hmm.
whole mission of the software, the mission of our company, is to improve perinatal outcomes and to reduce risk for laboring moms and their babies.
Fantastic. Well, we sit sometimes if we're working with carriers or TPAs, we're sitting at the other end or the far end of when things go wrong and it becomes a claim or it becomes a lawsuit. And this is just one of those specialties that, for lots of reasons that we all understand, end up generating a lot of cost for the entire system. Because when something goes wrong, there's usually a lot of emotion behind it, a lot of other things. So anybody who's trying to affect this particular specialty, I think is doing a great service for lots of providers out there. But give me a little bit of the backstory, like a little bit of your backstory and the backstory to riskLD. Like, how did you conceive of this idea? Where did it come from? When did you
Sure.
start to realize there was a need?
Absolutely. So I am a practicing obstetrician gynecologist. I maintain an active clinical practice, see patients a couple of days a week, both in the hospital and the office. And the need for riskLD, the really was spun out of about 10 years of quality and patient safety work at a large health system in Northeast Ohio, where I'm affiliated. And essentially, the team had been looking for many years at drivers of cases that had come up for quality assurance review, if ever there had been an adverse outcome for either a mom or a baby. And the team realized that almost any of these cases, almost all of these cases, could be traced back to one of two sources of error. The first being what we call a lack of situational awareness, which essentially just means that the clinical team wasn't aware of a problem until it was too late.
Mm,
Um, the second problem um, that was seen more at community hospitals as opposed to academic medical centers was patients not being managed optimally, patients not being managed appropriately, even after a high risk condition had been flagged. And so we stepped back and we said, okay, well, at risk of oversimplifying the problem, if this can be traced back to either not knowing about the problem or not managing it effectively, wouldn't it be great if we had a technology that we could deploy on our labor and delivery units that would help us identify and hopefully mitigate these sources of error? And long story short, we couldn't find anything commercially available on the market
Mm.
that met our needs. So ended up designing our own.
Wow.
Applied for a grant through an Ohio State agency that allowed us to develop and internally prototype and validate the software. And that technology was exclusively licensed from the hospital at the tail end of 2018. And that's what we're now commercializing as riskLD.
Amazing. Well, tell me, like, as you're navigating the market and you're introducing this to different facilities, do you have an inkling for what types of facilities maybe have the most to gain out of this, or should be considering it first? Because
So
there's some qualifiers there.
it is a great question. I think it lends different value in different kinds of clinical settings. And I'll give you some examples. There are really busy urban, inner city academic medical centers that have high volumes of high acuity patients. And in that clinical environment, it's really the situational awareness piece that's the biggest source of risk. It's not necessarily knowing what to do to manage the problem, because many of these institutions have maternal fetal medicine, high risk obstetrics in house or available for consult. It's more a question of, in that very busy, constantly changing clinical environment, sometimes critical information falls through the cracks. There's a
Mhm,
lab result that somehow gets missed. There is
mhm,
a fetal heart rate tracing issue that doesn't get attended to. There's an abnormal vital sign that isn't reported.
mhm.
And if you don't know about a problem, you can't manage it effectively. So in these really busy, high volume centers, sometimes the biggest challenge is knowing where to look first
Mm.
and knowing where to pay attention. Now, you contrast that with some smaller community or critical access hospitals where you might have a different set of problems. You might not have OBGYN providers. You might
Mhm,
have family medicine providers. You might not have medical doctors in-house. They might be
mhm.
remote or taking call from home. In some low volume settings, um, sometimes these types of hospitals don't see complexity with sufficient regularity to be able to recognize it when it
That's
happens.
right. Yeah.
And in that environment, what's needed is that robust, evidence based clinical decision support. I am presented with a high risk condition. What is the best available evidence for how I should be managing this condition? And am I equipped in this lower resource community hospital type setting to be able to manage this patient?
Yeah.
Or do I need to think about transferring her to a higher level of care?
Interesting. Okay. And we do a lot ourselves with critical access too. And it always, the pattern recognition of complexity always comes up, right? The lack of the ability to have pattern recognition with complexity. So how does riskLD work? Like it installs somewhere and it talks to something and it shows you something. Break it down. And if you have a show and tell, I'd love to see it.
Sure, absolutely. So I'll provide a brief overview and then pictures worth a thousand words. So I'll hop over to our demo environment and show you a little bit about how it works.
Great.
We are commercializing this as an app that is downloaded from the EMR App Store. So all the major EMR vendors, Epic, Cerner, Meditech, Allscripts, they all have app stores now that run on this technology called Smart on Fire, which is a standardized interface that third-party app developers like ourselves can write to. So the way it works is we have our software as an application installed in the EMR App Store, and it effectively gets downloaded by the hospital who's interested in having it as an overlay to the EMR build that's in place at their hospital. All of what you're about to see is data that is pulled from different parts of that EMR.
Mm,
We pull from over 130 data feeds per patient who is run through our system. So everything from the patient's past medical and obstetric history, every vital sign from the moment of her admission for that inpatient episode of care, any lab that's resulted, any medication or blood
mm,
product that has been administered. It's a whole lot of information that we mine and sift through and project on our user interface and which we use to power our alerting and clinical decision support algorithms. The
wow.
biggest problem with most EMRs is what we call disaggregation of information. You have information stored in multiple different parts of the chart. And so you have this hunt and peck model where if you are trying to access the patient's lab results, you need to click over here. And if you want her recent set of vital signs, you click here. But if you want to look at the 12-hour trend, it's in a different part entirely.
Yeah.
And when you are doing that sort of hunting and pecking, the information inevitably can get missed.
Yeah.
What we are doing is mining for all of that critical information. We're consolidating it and bringing it together on a single user interface. And we're also bringing together information on both mom and baby onto that user interface.
Wow.
Because when we take care of patients on labor and delivery, we're not taking care of either mom or baby. It's a dyad. And we're
Mm.
trying to optimize care for both. So I'm going to show you our demo environment. These are some hypothetical patients, but this will give you a sense of how it works.
Okay.
And Jared, you're able to see these 5 hypothetical patients?
I sure can.
Great. So what we're looking at here is a hypothetical labor and delivery unit, and we have 5 patients on our census. This is what we call the global view of a riskLD, and this is accessible as a tab within the EMR. Now, what we see here is all of the patient thumbnails have a black circle, but some of the patients have a red circle. Now, the red circle corresponds to a new and unacknowledged alert that has just fired for that patient. Now, an alert could be an abnormal vital sign. It could be a new high risk condition like preeclampsia or intraamniotic infection. It could be a sign that labor is not progressing normally. There are a number of conditions that we could alert against. And we can also customize that to the hospital. So different hospitals, different units might have different alerting
Mm.
thresholds. But what we see here is that the patient in bed 4, Lisa Jones, and the patient in bed 6, Jane Smith, they both have new and unacknowledged alerts. These have just fired real time. We want to double click on those to figure out what those alerts are and to make sure that those problems are being addressed.
Love it.
Now, when we look at the black circle contains essentially a running tally of all of the alerts that have fired for the patient since her admission to labor and delivery.
I
So this
see.
essentially becomes a marker of acuity for your unit, because
Hmm.
if you are the charge nurse or you are the attending physician and you're looking at your census of patients and you have one patient for whom 2 alerts have fired and another patient for whom 37 alerts have fired, your patient with 37 alerts is probably your higher risk patient. And you
Hmm.
want to make sure that you have an experienced nurse at the bedside, that the attending is ideally in house and involved with the plan of care, that the charge nurse is aware of the plan of care. So, this is essentially our air traffic control. This is how we identify patients who need intervention and allocate resources accordingly.
Love it.
So I'm going to click on this first patient, Betty Goodcase, to give you a sense of what's on her patient-specific user interface. And again, this view could also be accessed from within the patient's chart in the EMR. Once
Um,
riskLD is downloaded through the EMR App Store, there's a riskLD tab that would appear in the patient's chart. You, as the clinician working on labor and delivery, clicks on the tab, and this is what you see. Now, I don't need to get overly clinical for those in your audience who haven't worked on labor and delivery, but essentially what we've done here is try to consolidate all the relevant fetal indicators and all the relevant maternal indicators and bring them together on a single color-coded user interface. So a little bit of a tour here. We have the
mm,
patient's name, her identifying information, her G's and P's, which is the number of pregnancies and number of previous deliveries. We know
mm,
her gestational age, and we know the estimated fetal weight of the baby. So that's all kind of on our header at the top. On the left here is a longitudinal view of the fetal heart rate baseline. This is telling us over time what's happening with the baby's heart rate since the onset of labor. This graph is showing me a visual representation of the labor curve. It's plotting 2 simple variables, cervical dilation and fetal station. So I have a visual snapshot of how the labor has been
mm.
progressing over time. Now, if I go over to this part of the chart, I see a couple rows of charms, some of which are lit up. The first row of charms pertains to pre-existing medical conditions. So these are conditions that the patient walks onto the labor unit with these already in place. This particular patient has pre-existing diabetes and chronic hypertension, which are conditions I want to know about if I'm managing her labor. Now, the system is also telling me that she's at high risk for what's called a shoulder dystocia, which is an obstetric complication where the head delivers and the shoulders get stuck.
Mm.
It's also telling me that she's at high risk of a postpartum hemorrhage. And we'll talk in a moment about how we arrived at those determinations. This
Indeed.
bottom row here is lighting up based on certain intrapartum conditions, things that happen or are flagged while she is in labor. It's telling me her group B strep status. It's telling me whether or not she has her epidural. It's telling me the length of time since rupture of membranes. And the last bit of our tour here is basically all the parameters that we want to track when we're assessing how a labor is progressing. We want to know the stage of labor. We want to know if membranes are intact or ruptured. The is oxytocin on, and if it's on, at what rate is it infusing? What is the labor progress doing? What is her cervical dilation and
Mm.
fetal station? How is the baby tolerating labor? Have we seen any late or prolonged decelerations? This last section here is essentially what we call a maternal early warning system. It's telling me mom's blood pressure, temperature, heart rate, respiratory rate, pulse ox, and then after delivery, it is tallying her quantitative blood loss and her urine output. And the last piece that I want to show here is we actually have a scrolling toolbar that allow me to scroll backwards and forwards.
Oh, look at that.
Now, this is really
Right.
useful for handoffs of care. We have a lot of
Mm.
patients who are coming in to have labor induced for a variety of medical or other indications. Sometimes these patients are on the unit for days at a time, and there might be multiple handoffs of care. So when you're assuming care for the patient, you want to know things like, when did the patient progress from latent to active labor? And when did membranes rupture? And has the Pitocin been on or off? How many times has it turned off? How many decelerations are we seeing? That's information that's not easily accessible in most EMRs. What we've done is extracted that out.
Yeah.
I have a few other things I wanted to show with the alerting, but I'd stop there just to see if there are any initial questions, Jared.
I mean, it's great. From an information architecture perspective, being able to dashboard all of these things, and you give a time component to this with the timeline. It's great. I mean, I feel like I could look at a chart like this and at least understand what I'm supposed to pay attention to. So just good from a software person to a clinician. This is a pretty good software design so far.
No, thank you for that feedback. I think our real differentiator is that we were designed by OBs and OB nurses for use by OBs and OB nurses, which is to
Yeah,
say
that
that
makes the difference.
we really know how we want information to be packaged and presented. Those of us that have worked in the trenches on labor and delivery. So it's a rather simple design, but it sort of has everything that you need.
Yeah,
Now, the
I
other
love
point
it.
I'll focus on here is we see this bell in the upper right-hand corner, which is telling me about the two alerts that have fired for this particular patient. So it's telling me that this patient has a risk factor for shoulder dystocia, and it's telling me why. One, because she has a history of a shoulder dystocia during her previous delivery. She has a larger baby with an estimated fetal weight greater than 4,000 grams, and she has a history of diabetes. So these are three known risk factors. Now, it is widely accepted that a shoulder dystocia is impossible to predict with any accuracy or to prevent should it occur. But you can mitigate your risk by counseling the patient, documenting that counseling in the chart, and making sure that there's optimal preparedness on the unit, that both the nurse who's at the bedside and the charge nurse are aware of the risk in the situation. We also have links to ACOG, the American College of Obstetricians Gynecologists. We
Mm.
have links to ACOG guidance on this particular topic. So what we've extracted here is content that comes from either the practice bulletins or committee opinions that our professional body publishes on this issue. So if you're at a community hospital and you're trying to remind yourself, well, is there a weight, an estimated fetal weight at which I should consider a C-section versus allowing this patient to labor, and you can't exactly remember what those thresholds are, we're displaying that content here, so
Amazing.
it's easy to access at the point of care.
Fantastic. Well, so tell me, you've been able to deploy this to places. What have you learned? Do you have any kind of stats or anything that you like to talk about, or just kind of impact assessments of the tool in practice?
Great question. So we are still early stage. We went live with our second hospital the tail end of October. What we've seen from some early looks at the data is we're starting to see an overall narrowing in what we call the time to treatment for high
Mhm.
risk conditions. Now, that is a process measure, but that can be a proxy for an adverse outcome. What we are looking at is the time from when a high risk condition was flagged to the time at which treatment was administered. We want to shorten that time. And what
Yeah.
we've seen with preliminary analysis is that we are able to incrementally narrow that time and also reduce variation in time to treatment
Mhm.
from having these extreme outliers, cases that were treated hours after the condition ideally would have been
Yeah.
diagnosed to much closer to the time of diagnosis.
Yeah.
We're in the process of consolidating some more just kind of end user satisfaction with the tool. Um, One of our biggest metrics that we want to track is do people feel that it makes their job easier?
Mhm.
Which anecdotally people have shared that it does. Our goal is not to create any additional work. What you'll note about the interface that I was just sharing is it's not a write back. There's no additional documentation. There's no additional workflow. It's
Yeah.
just consolidating information that's already in the chart and making it easier to take actions against that information. So the
I
hope is
mean,
easier.
as a doctor, I'm sure it's happened at least once that you've been handed technology that makes your life more difficult, right?
Well, exactly, and that's always that's the hurdle that we have to overcome when we're introducing the tool. Is
Yeah.
to as soon as we come into the unit with a new technology, that's the fear. Is oh gosh, I'm going to have to chart elsewhere. I have to use a different screen. I have to use a different device. I'm already overwhelmed as it is, and
Yeah.
so we have to kind of really invest in walking end users through. Actually, there's no additional work. This is how it's a time saver.
Well, there's a lot of risk and patient safety people that listen to this podcast, whether they're at carriers and TPAs, and they're trying to encourage their insureds or their clients to implement and think about things that are upstream from risk in order to help it downstream, right? So there's a lot of that. Certainly, they're looking for advice and ideas to bring back to their clients and their insureds to be able to help. And then we've also got folks that are sitting at hospitals or at clinics. They're managing risk, they're managing patient safety. What are you looking for in terms of sort of an ideal customer? Like what and how do people reach out to you and get involved? And
It's a great question. I think for this to be successful, it takes strong clinical leadership and clinical sponsorship, and also close collaboration with the hospital's IT department. We've had situations where there might be a great clinical champion, but that clinical champion really has no sway over IT decisions that are made at the hospital. And as much as they might want this tool, they sort of can't advocate enough to get it, in the pipeline
yeah,
for projects to be implemented. So I think having that sponsorship, that leadership on the clinical side, but with that close collaboration and buy-in on the IT side is really what sets it up for success. I will also say that the partnership with risk management is really key because risk managers, as you were saying, appreciate the value of addressing upstream drivers of risk,
yeah,
and are positioned to support projects like this, might even have the influence over IT that clinicians do not.
yeah,
So it's realizing that decisions at hospitals, particularly large health systems, are not made in silos. It requires collaboration across multiple departments. But where we've seen the most success is when there's the interest on the part of clinician, there's the buy-in from risk, and together able to influence and get that buy-in from IT.
yeah. I mean, it's so important. And we've seen some of the big nuclear verdicts in the last year, 2 years come from OB-GYN as a specialty. We have clients that just send us reviews for OB-GYN cases just because there's so much tied up in that. There's so many things that do go wrong. There's a lot of babies being born in a lot of places, right? And so there's just a large surface area of risk there. And the idea that you can, with a single dashboard, bring that risk together and elevate for the doctor, no matter what they're training, what is critical to look at now, is just I can't it's so much value in that. So hopefully those who are listening are thinking, hey, you know what? I'd like to suggest some solutions like this to my hospitals, or if I'm at a hospital to suggest this. But I just love it. I love everything about it. Well, anything else that you'd like to kind of leave us with?
The other
Um,
piece that I would share, Jared, is how useful it is for hospitals as part of their quality assurance reviews and their
mm,
processes, for two reasons. One, if you are reviewing a case, and you are kind of replaying the riskLD screen, you have all the information at your fingertips that you would typically spend, maybe weeks sort of, leveraging chart abstractors to try to pull that story together. You
Yeah.
have the whole story together in front of you. So it really does make those reviews much more efficient. It also really serves as a great teaching tool. If you have new orienting nurses or medical
Oh
students,
gosh. Yeah.
it puts the whole story together. The last piece that we're able to do, which I'll show you some quick screenshots of, is the reports that we're able to issue with our software. Now, what we realized, I'll scroll to the top here, is that because we collect so much data from the EMR to power our alerting and decision support algorithms, we're in a position to analyze that data and issue real-time reports back to the hospitals about their
Wow.
areas of risk. So we can tell them in real time, how frequently are you encountering some of these high risk conditions and how effectively are you managing them? So this is a hypothetical report. This is all hypothetical information, but it's based on actual reports that we do issue for our clients. And I'll just give you a quick tour here. So we're showing just how the delivery volumes are flexing up and down month to month. We're showing the frequency with which they're encountering certain high risk conditions, the different kinds of hypertensive disorders of pregnancy, the cases of shoulder dystocia or OB hemorrhage, intraamniotic infection, and diabetes. The interesting story, one of our hospitals, they realized after a couple of months of looking at this dashboard that their rates of diabetes on their unit was much higher than they thought it was. And they
Hmm.
realized they needed to implement some additional education and training on managing diabetes in a laboring patient, because it's very different from managing diabetes in the office. But they didn't have that visibility before our dashboard of, wow, we have a significant percentage of patients on the floor that have either pre-gestational or gestational diabetes. We're able to capture the timeliness of nursing documentation. This is a real pain point for some hospitals, particularly hospitals, as a lot are now, that have traveling nurses that might not be aware of hospital protocols or policies for how frequently to take vital signs or assess pain or interpret the fetal heart rate strip. We can feed back to the unit how compliant were your staff with documenting on time versus what percentage of the time was that documentation delayed, and are there opportunities for improvement? And this last section that I'll direct you towards here is this time to treatment section. So we talked about tracking this as a process metric, but of all of this, to give you an example, with a case like intraamniotic infection, which is an infection that can develop within the uterus during labor, we can tell you of all the cases that you had in the last month, how many got treated within the hour, which is the ACOG standard, versus how many had delays in treatment of between
Wow.
1 and 2 hours or greater than 2 hours? Or
Yeah.
were there any cases for which there was no treatment? And so we do this right now for three conditions. We do it for intraamniotic infection. We do it for severe preeclampsia, measuring the time from that diagnosis to the administration of magnesium sulfate. And we also do it for treatment of severe hypertension. And what we do is hand these reports back to the client, and the MRNs for cases where there was either no treatment or significant delays in treatment will get reviewed. And ultimately, it's the determination of the hospital, of their L&D or their quality leadership. Did we meet our standard of care here? We're not necessarily accusing anyone of practicing bad medicine. We're just saying, hey, our system flagged that there was a more than 2 hour delay in administering the antihypertensive. Uh, why was that? And the teams can really look into why. That's the other piece that's
Yeah.
valuable. If there was a significant delay in administration of antibiotics, was that because we didn't recognize the condition? We didn't place the order wasn't validated, the medication didn't come up from pharmacy? At what point in that chain did things break down? If you don't know the root of the problem, it's hard to kind of implement your solution. What this does is really focus those teams on cases, which may have not have resulted in adverse outcome. Maybe it was just a near miss. But we can say, you know what, there's a delay in care here. You might want to look at what was driving that, and
Yeah.
can we implement systems, processes to prevent that from happening?
And that is consistently the best philosophy that I see as we work with, we ourselves work with different hospitals and clinics. The ones who are looking for the things that haven't ended up in a unintended outcome, the ones that are looking ahead of that, the ones that are playing proactive. We all have limited resources. What you're doing is you're helping elevate the things that can be looked at to find the opportunities to make delivery better, right? And so I love everything about this, being able to help play ahead rather than reactive, and things get punitive and reactive later down the stream, right? When these things are becoming lawsuits and other stuff. I think our goal in healthcare should be, you know, uh, being proactive.
Exactly, exactly. What I'll share with you, Jared, is that we've actually have some clients that have thought about leading with this report. And what we
Mm,
can do with our software is actually kind of install it in the background so that you don't
mm.
have any end users that are working with it. It's not actually alerting in real time on the unit. We're just running these reports on a
Oh,
month-to-month
fantastic.
and looking
Yeah,
at the data. And we
yeah.
use that to identify areas of risk. And you might find out after a couple of months, we haven't missed a single case of severe preeclampsia in 3 months.
Mm,
We are really good at missing that. But you know what? We had a couple cases of OB sepsis that we didn't pick up because sepsis presents differently in the
yeah.
obstetric patient. And so using the results of this reporting tool to then design a solution that maps to the areas of risk.
Mm.
So
Fantastic. I love it. Well, Dr. Porter, this was great. How do people find out more? Where should we send them? Obviously, we'll put links in the show notes here, but where should they go?
Absolutely. So I would direct you to our website, riskLD.net. Has all our contact information on there. Folks are welcome to contact me directly, sporter@riskld.net. And would be delighted to hear from anyone that's interested in a demo or learning more about what we do.
Fantastic. Well, thanks for the work that you do. I love anybody that's using good technology to solve some real problems. Well, for everybody else, thanks for listening to Reimagining Healthcare, a new dialogue in risk and patient safety. Subscribe and share if you found it valuable. And if you'd like to participate as a guest, again, just email us at speakers@medplace.com, and be sure to follow Steve. Again, links that will be down below. And Steve, thanks so much. This is great.
My pleasure. Thanks for having me.
It's good to see you again.
Great.
All right, we'll talk soon.
Thanks, Jared.